I should be doing that thing. Okay, Sarah, go ahead.
And welcome everyone. My name is Saya Jackson. I am glad to be co-host for the show today. Just a little bit about me for those who are new to me is I'm a life and transitions coach. I specialize in working with individuals who are going through challenging life transitions in the area of their career or their relationships or their faith. Today, we're looking at the question of chronic pain. In many advertisements, at least when I grew up, the medical advertisements, when they were advertising a new drug or maybe a new procedure, most of the advertisements ended with the words, if symptoms persist, please see your doctor or seek medical advice, or something that would point you to a physician. That was all good until I learned a term called idiopathic. You know, the way the world of medicine does not like to speak English, they conjure these big words, often to make sure that very simple things sound very complex. But idiopathic simply means a disease or a condition we do not know the source of the pathology. We don't know where it has come from. And we keep making fun that idiopathic then means the doctor is an idiot and your state is pathetic. May sound harsh or at times funny, but at times the symptoms do persist, and yeah, the doctor is an idiot and your condition is pathetic, and the pain now just persists, and all that they can do is help maintain you in that state. And the big question is really, what do you do? The experience of pain is not only suffered by the sufferer. It is, in a sense, collective. It is a shared thing. It is not shared equitably or equally, but it is shared because the individual taking care of the person with pain is sharing in the pain, if at least nothing else vicariously. But certainly the person sharing or going through the pain is suffering. And this is true whether the pain source is visible, like in the case of an injury or some cancer, or when it is invisible, in the case of psychosomatic, things that are happening psychologically but affecting individuals in their body systems. In fact, the question of chronic pain is very interesting that in doing the research, it's normally I would try dig out what happened in traditional Africa about the question of chronic pain or what happened. We really don't have much literature on the same. What we do know, however, is when people experienced persistent pain that brought them to the point of despair or to the point they felt they were no longer wanted, they would be sidelined because there were leakage on the resources. In some communities, they would be taken out to the forest to be left to die. In others, they would seek one way or the other to end their lives. So the question of human pain is real, it's deep. The solutions are a bit getting better, but we need to know how to go through them. You see, as a transitions coach, I know transition is what happens in you when change is happening around you. We're not in charge of change. We may not be in charge of the cancer that causes the pain or the accident that leaves us in a certain condition, but the experience, the psychological adjustments we need to make, which is actually what we call transition, is what we are responsible for. And we need to become better equipped to manage this because unlike other conditions, chronic pain puts you in this perpetual state of transition because you're not really moving from one state to the other. You seem suspended in this middle place, and you will need psychological tools, you will need social coping tools in addition to the medical ones. It's a topic so heavy, it's a topic so severe that many of us would rather skirt around it. I'm a Christian, and so I thought of what would the Bible say about this? And the interesting bit I found was in Psalms 23, of all places. is that particular line where it says, "You anoint my head," in the 23rd Psalm. It picks from the analogy of what shepherds would do. There are little bugs, which what they do is they lay their eggs on the nostrils of sheep, and the eggs then move in, and then the larvae, and then the adult forms hatch in the brains of the sheep, which causes chronic pain for the poor sheep. It's so severe when you see the sheep suffering. They brush their heads against bushes, they hit their heads against stones there, because they're almost feeling itchy, very itchy inside. And in many cases, the pain is so persistent that some of the sheep, in their attempt to get relief, end up ending their own lives. As a precaution against this, what the shepherds would do is they would take a mixture of oil with spices and some other medicinal value stuff, and make up a concoction that they would pour on the head and make sure it covers the openings of the head, the ears, the nose, the eyes, the mouth, so that when the sheep would be traveling through the region where the bugs would, even if the bugs would deposit their eggs on them, do not find a way to penetrate them. So even in the Bible, the attempt to address the question of persistent or chronic pain speaks more of the preventative rather than the palliative or the curative. And it is time that we genuinely need to have this heavy but important conversation. So somber that I'm equally somber today as I say, let's talk, let's have this authentic conversation about chronic pain. Back to you in studio.
Thank you, Saya. So, Dr. Nafula, do you want the doctor name, or we can just drop it? But Dr. Nafula, let's start with the definition of pain. Then you can delineate between, I mean, if there's chronic pain, there's acute pain. So let's start with just what is pain.
Okay, so pain, first of all, pain is a
sorry. Just give me a minute. Because you're new to us, just jitambulishe.
let me introduce myself. Yeah, sorry.
Yes, yeah. That's
sorry about that. My name is Esther Nafula. I'm a medical doctor by training. I'm specialized in palliative care, and I head the pain and palliative care unit at Kenyatta National Hospital, which is our largest referral hospital in Eastern Central Africa. So we see a lot of patients with chronic pain, and I'm delighted to be part of this discussion this evening. So I will go straight into talking about what pain is. So first of all, pain is a very subjective experience. The way you experience pain is not the same way I will experience pain. Even if we both had a headache, we cannot experience it the same way. So only the wearer of the shoe knows where it pinches most. The person experiencing the pain is the best person to tell you about their pain. So scientifically, pain is thought to occur because of tissue damage. So we describe the pain based on the tissues that have been damaged. So we have acute and chronic pain. So acute pain usually will last up to 3 months and is associated with injury, for example, surgery. So we give it a cutoff of 3 months because most tissues will heal within that time. After 3 months, we then consider that pain to be chronic pain. So pain, generally, we look at it based on which tissues have been injured or which tissues are hurt. So if we were to go scientifically, we would call it nociceptive and neuropathic, where nociceptive pain is coming from any tissue that is not a nerve, and then neuropathic pain comes from damage that is caused by nerves. Thank you. Back to you.
Okay. And since we have the delineation already, do we know what in our setting, what is the source of most chronic pain? Because acute pain we can manage, but what is the source of chronic pain globally and then in our Kenyan setting?
Now, the causes of pain are very diverse. And it's very hard to say that this is the commonest cause of chronic pain, for example. But basically, we look at pain in 3 ways. We look at pain based on the duration, based on the tissues, and then based on the underlying cause. So we might have, for example, chronic pain can be caused by diseases like diabetes, cancer, or treatment for those diseases. And then sometimes people have from accidents can get chronic pain because of damage to their nerves. Then we have pain that comes from illnesses like sickle cell. So sometimes they get flare-ups of pain. So usually we just look at the common causes to be trauma. So these are things like accidents, fractures, and then now illnesses. And the common illnesses that we see causing chronic pain, as I said, there's sickle cell, there's autoimmune diseases like fibromyalgia, lupus, then diabetes can cause chronic pain where the nerves are affected. Then we have cancer that also causes chronic pain.
Thank you. Mukimba, from your end as a psychologist, do you see when do you get patients who are referred to you because of pain?
Hi, everybody. So I think the part where a psychologist comes in is when all the other physicians have been able to rule out all the other sources of the pain. So this pain is persistent, this pain is chronic, it still continues persisting over a period of time. And that is when I think multimodal approaches, like combining both, medical approaches, painkillers, and as well, psychological treatments like cognitive behavioral therapy can come in when we are, trying to figure out what the exact source of this pain is. If we cannot find a physical source for the pain, if there is no definition, if there's no way the doctors can come up with an answer for where the pain is being sourced from at that point, I feel that's when we come in. Though I feel from the beginning, when people are experiencing persistent pain, multimodal approaches should be what we start with from the get-go, instead of waiting until when there is no other option. That's when we label them as psychosomatic. And that's when now, like, the psychologist comes in and we try and figure out whether this is either complex PTSD or it is probably sourced from an actual traumatic experience. But yeah, basically the psychologist comes in when things have all other causes of action have been ruled out, though the ideal approach, or what would be ideal, is if trauma-informed care was brought in from the beginning. Have I answered the question?
Yes, you have. Thank you. Thank you very much. So let's start with Brenda. Brenda, just tell us a bit what you can share, what you're comfortable sharing about your living. You said you're a chronic pain no Takayasu's warrior. So just tell us a bit about yourself, and of course, please remind us that you're in hospitals. We truly appreciate you, and just tell us your journey about pain, with pain. Kizungu Misha.
Well, my name is Brenda. I am currently in hospital. Lakini hata tukiwa hospitali lazima tuweke shower gift to hang you can. I'm not saying about that out here. I have a list of diseases, but I think the one that has caused most havoc is one called Takayasu's arteritis, which is very rare. So I'm very special. And it's a rare form of vasculitis that causes inflammation in the aorta and its branches. So for me, unfortunately, it caused an aneurysm in my ascending aorta. That's why I had open heart surgery. And then it's caused some blockages in my arms and in my brain, in some arteries in my arms and in my brain. Currently, I'm in hospital. I've been here for about 3 weeks now. Losing my ability to walk. Unfortunately, I have something called spinal stenosis, which is a lot of pain in my back, and it's causing a lot of weakness in my legs and so Nation Doctor. Can we both understand Swahili and English? Can I use both?
No, because sometimes we get Ugandans.
Oh, okay.
Yeah, so just
Yeah.
them the English.
Okay.
Yeah.
So yeah, so it's difficult for me to walk, and so now I'm in rehab. Well, I spent half of this day, half in ICU and half in rehab. So now I'm in rehab trying to remember how to walk again. I don't know what else to say, but apart from being a warrior, I guess I just graduated in December, so I didn't let disease stop me from achieving my dreams. So yes.
Okay, and if you were to put your own dictionary definition of pain, what would you say?
Pain? Ooh, I have not thought of that, but I would say it's my body's way of telling me that something is wrong and it needs my attention. That's
Okay.
just the simple way I would put it.
Okay, and this is from the work you've had, or this is a definition you've always had?
That's how I've always said it, because that's how I always tell the doctor, and that's how I always know when something needs attention. Like recently, how I got my legs refused to move. I was just like, I know something is wrong, and I cannot. I'm just like, if it's too painful to move my leg, then I know something is wrong, and I need medical attention, especially if it's worse than it's ever been. So it's how I know, it's how I gauge I need help.
Okay. And Dr. Nafula, would you kindly touch on that? Because I don't think people know that pain has a function, and Brenda has brought it out very well. Would you care to piggyback or add on to that?
So yeah, what she says is true, that pain is the body's way of telling you that something is wrong. Actually, 80% of patients come to hospital because they feel pain. If they didn't feel pain, then their symptoms, they would ignore whatever disease is there. So just the way she's put it through experience, that when you feel pain, there's a problem in a certain part of your body based on where you're feeling pain. I think that's what I can add to that.
Thank you. Trix, we are not like me, we are not using your full T name, so Trix it is. Just if you're able to share your journey with pain, because you have a common condition amongst we people of Western and we people who came from following the Nile and the Congo. Just talk to us about it.
My name is Teresa Adhiambo Ouma. I suffer from sickle cell disease, but I think in my later life, I've come to realize that it's something that you can easily manage as long as you know how to manipulate your body. Sickle cell is a challenging disease because it's very unpredictable. One time you're well, another time you're not okay. One time you're running up and down, 5 minutes later you're crying because something has happened to you. There's a lot of pain in the body and all that. So I guess the unpredictability of it is what makes the disease a bit difficult. And then the inconsistency of not knowing when or where or how the pain is going to affect which part of your body. That's also, I think, a challenge for most of us. So yeah, I do suffer from sickle cell, but it's something you can easily learn to live with as you grow.
So when did you know that you have sickle cell?
I think I knew as a kid, but I really didn't really fathom the depth of it until I was in high school. Yeah, about age 16. Because at least age 16, you try to leave your parents' care and try to take care of yourself. So I was more aware of myself when I was age 16 in high school. And yeah, I guess so.
Okay, and the same question I asked Brenda, what's your definition of pain?
It's a siren. I echo what she said. It really indeed is a siren. Like when I lay down at night, fun enough, most pain, you'll always notice something is wrong with you when you're lying down at night. You know, so pain for me is not a bad thing. It's more of a siren that something is wrong, because if we really didn't have that siren, you wouldn't really know what to fix. Yeah, if you didn't have a headache, you wouldn't know that you need to probably check if you drank enough water or have enough oxygen, or you were carrying something heavy that was cutting the artery to your brain. So pain for me, I embrace it because it at least tells me something is wrong, and I can fix it faster because at least I know, you know.
Okay, thank you. Mukimba, I think you have something to say. Go ahead.
Oh yeah, I felt like it was really important for me to share that there is a connection between the fact that, you know, pain does cause psychological problems, and at the same time, psychological distress does cause more pain. So the association of pain, chronic pain, and, you know, the mind and the brain as well is really important. So even just having a space for people who are in chronic pain and in chronic pain management, definitely having just a space where they are heard, where they're validated, their stories can be told in their words and not in whatever we want. You know, we want their stories to sound like, and they can narrate their stories and feel completely validated, I think also makes a huge difference as they process through their pain. And I have, at least I have seen that help a lot of people. So maybe the warriors would be the ones to probably give an assessment of how, you know, being able to be in a space where you can be able to talk about your pain and your narrative in your words, and not necessarily in what society wants to hear, but in your words specifically, I think makes a huge difference because they're both interconnected.
So Sai, I want to come to you because I'm just thinking, even in our own mother tongue, there's no, you know, the way we have especially the visible disabilities, we have even for sickle cell, we have a name for it. We have everything, but the chronic pain that's not seen, is there the fact that we don't even have a name for it? Does it affect how we deal with the issue of chronic pain? I don't know if you understand, because okay, let me frame it this way. I'm currently involved in a dementia project. The whole continent, we have interviewed from Cape to Cairo. There's no word for dementia in the in African languages. So we name it other things, kusahau, kurukwa na akili, all those things, but not dementia. So I'm just wondering if the same applies to chronic pain. And we'll start with you, then we'll go to Dr. Nafula.
I agree. So when somebody has chronic pain, in Luo we call them omteshere. Omteshere just means sickly. And of course, groups many things in it. I'm sure there'd be other words in other tribes for people who are sickly, but the sickly word does not embrace specific, you know, maybe certain conditions were not diagnosed as would know. Like really, if I asked my grandmother for a word for takayusu, it's punishing her. She probably wouldn't. However, just like it's true in every other area of life, it's also true in chronic pain that what you can't label, what you can't name, what you can't call, you cannot confront properly, because you first have to admit it's a thing, and you almost need to know what thing it is for you to confront it properly. In cases like Trixie's and Brenda's, where the condition is visible, there's a bit more empathy, and then Two, there'll be, I'm speaking in an old African setting, there'll be A, more empathy, and B, there'd be probably clearer attempts. But in the case where somebody is suffering from something invisible, it's not accurately, totally visible. I'm thinking like a certain forms of endometriosis or various other conditions that are not visible. It became, just like it is now in the African context, it'd be very difficult to give them the requisite support, because it would either be attributed to spirits. People would say like, hey, this person is under spirits attack, or laziness, like this person is pretending. And you see in both extremes, when you either feel somebody is pretending or you feel somebody is possessed, the approach you apply to that is going to be different. Recently, I've been studying for mental health certification, and I learned very interesting things, that there are some conditions that have chronic pain. The external manifestation look like possession, like somebody ticks the boxes of everything that looks like possession. They're in pain, they have manic and stuff, and they're simply solved by a pill of serotonin. Like just a pill of serotonin gets the person properly in position. So yes, mislabeling or lack of labeling or lack of awareness of a pain situation, whether a visible one or an invisible one, does affect the way we do approach it.
And Dr. Nafula, am I saying that? Yeah, Dr. Nafula, is this your, because, okay, for me, who has had a foray in this land, we just, like Brenda, I will tell her she has Takayasus and we'll move on. But in Kenya, where hypertension already is just shinikizo la damu, how on earth are you able to, the same question, is it that when we lack a name for it, we don't treat it the same way? Is this your experience as a palliative care doctor?
First of all, I think that patients who have chronic pain are misunderstood by a lot of people, by their families, by healthcare providers. These patients learn to live with pain. It is not that they don't have pain, but they sort of learn to live with pain. The pain becomes part of their life, to the extent that when they say they're in pain, nobody believes them. Their family will tell you this person is not in pain. This is the way they usually are. They'll come to hospital, they'll be told it is psychological, it is not pain. Because people expect that a patient with pain will be screaming from the gate of the hospital. So chronic pain is greatly misunderstood. It is actually a syndrome that is as part of the diseases. Our ICD-10 and ICD-11 recognizes that pain is a disease, but then because it is poorly understood, patients do not also get proper attention, neither from the healthcare world or from their family. And that's why a forum like this is good for us to discuss, for people to know that just because you cannot see someone behaving like they're in pain does not mean that they do not have pain. Saya has mentioned a disease like endometriosis. A lot of women with endometriosis suffer a lot of period pain. When they go to emergency rooms, most of the time they're told period pain is normal. Just take a Panadol. It is not that bad. It is in your head. Why don't you, just tough it out. So it is high time that people started paying attention. When someone is saying they have pain, don't invalidate that experience. Try to understand, how can you be of help? Mukimba has mentioned that a lot of patients are referred there as a last resort when people don't know what to do. But psychological care should be part of pain management, because pain has a psychological component to it. You can imagine that patient who is poorly understood, the kind of mental torture they have in their mind. You are not able to go to work because you're in pain, you've lost your job, you are going from doctor to doctor, nobody's believing you. So it is good for us to incorporate also that psychological bit. And basically just what I said in defining pain, believe the person who is experiencing the pain. Don't dismiss, ask them about that pain. What is your experience of pain? What is this pain hindering you from doing? And with the medications you've tried, if they're not working, how else can we be able to assist in making that pain better? Thank you. I can see Brenda's hand is up.
Okay, Brenda, and if on top of what you want to say, what has been your experience with we healthcare workers? Have we invalidated your pain? And whatever you are gonna share, just go ahead.
That's actually what I was going to share.
Okay.
So let me turn on my video. My experience has been this. It depends with which hospital I go to and which, especially emergency room I go to, because unfortunately I've had to go to the ER quite often.
This is
because
your Kenyan or your US experience?
my US experience.
Okay.
In Kenya, they did not fully understand. I feel like the doctors who I saw did not fully understand my condition. What they saw was that I was in pain, and I was definitely in pain. And I feel like Takayasu's was such an out of pocket idea that I was diagnosed with fibromyalgia. So I was treated for fibromyalgia back at home. But then even when I got here, that was the diagnosis that they kept on treating me for, or treating me with. But even when I had the fibromyalgia at home, and I had family here, and people would hear that I have fibromyalgia, they'd tell my family members, why don't you tell her to go see a psychologist or a psychiatrist, because it's all in her head. That is what most people thought. And some would come from family, like cousins or family members who are medical professionals, and it would be like, it's not in my head, I'm actually in pain, But that aside, that was my experience in Kenya. And it constantly felt like I had to fight to get the resources to go see the doctor, to get the resources to the doctor to be. It was a constant struggle. But then here we are in America, and the struggle is sometimes when I go to the ER and they're too busy, and sometimes you get a doctor who doesn't take the time to look at your chart. Because if you look at my chart, you'll be like, oh my goodness, this girl has gone through a lot. She's not seeking drugs. But when I go right now, when I go and maybe they're too busy, or maybe I end up sometimes I end up with an ambulance and they send me to a hospital that I'm not used to. And I get like a doctor who probably get too overworked because of what's happening in healthcare now. And I try to explain to them. So I have this thing, it's so painful. It is so painful that I don't even talk about it. It's called a vascular necrosis. So my bone is dead due to it doesn't have blood flow. So it's one of the most painful things I have had to endure. And I think this one time I went to hospital for it because I'm in so much pain the whole night. And I tell the doctor, I can't stay home. All the medicine you've given me, even Oxy, because at that time I just had open heart surgery. I was like, even Oxy is not working. We need to find something. So I'm just going to hospital because the pain meds that I have at home are not working, and the pain is beyond me. So I'm just like, let me go see what they can give me in hospital. They thought I was seeking drugs. I'm like, if I was seeking drugs, I have Oxy. I don't need drugs. And then the doctor was like, have you tried meditating? And I was like, how is this the medical care that I'm getting? And it's not once or twice. I have had to constantly have to advocate for myself, to be like, hey, I am in pain and I am not seeking drugs. This is something that I always have to constantly say. And I'm like, even the drug you're giving me right now is not going to help me. I need something stronger, or we need to find another, like a family of medicine that treats pain a different way, because what is you're giving me is not working. So it's always a struggle. I always joke that I am now a doctor, a patient, a social worker, because I always have to advocate for myself. Sometimes it's exhausting. I say, you know what, I can't fight anymore. Sometimes I'm like, it gets tiring because I can't be fighting my disease. I can't be fighting my insurance, and I can't be fighting my doctors. It's too much. So that's where it's at.
Thank you. Trix, what's your experience? Have you been called a drug seeker also? I feel like this is a US problem. Is it a problem back home? Trix, I know you were enjoying a walk. Are you still there? Okay.
Sorry, can you hear me?
Yes.
I'm sorry, I'm at the countryside, so it's a bit windy. Of course, like it's a universal problem. There are days when like the drugs in the house, of course, we who have chronic pain have to have some painkillers in the house that are not kawaida, not Panadol, not the Panadol or the aspirin we're used to. You have to at least have something slightly stronger. And when that is not working, then this one is getting worse, so we need to seek for help. But now when the doctor sees your face, like let's say every month or twice in a month, they do have this mentality that maybe you're a junkie. And I do know that some of us are junkies, but sometimes it's also good for them to at least assess, is this one really a junkie or are they struggling with pain right now? Because sometimes you're literally writhing and in anguish and pain, and you're rocking back and forth, and you have tears in your eyes are red, you haven't slept, you tried to sleep till morning, but it couldn't reach morning. So at 3 a.m., you're like, yeah, let me go seek better help. And you get there and you get a nurse with an attitude who's asking you, when was the last time you were here? Oh, you were here 2 weeks ago. What did we give you? We gave you pethidine. No, we can't give you pethidine again. We're giving you Panadol. And then, when you're being given Panadol, when you already tried Panadol 2 hours ago and it wasn't working, well, it's frustrating. And now when you're frustrating a patient that is going through pain, you're even making their pain worse. You're making the situation more stressful and stuff like that. It's a universal problem. So I would concur, yeah.
Okay, and I'm just wondering, Dr. Nafula, because I know there was a push in the, where were we? In the early 2000s, and now with the revelations of how the opioid industry was being pushed in this, pharmaceuticals were being pushed in this country, those are pushed to make pain as a vital sign, both from the US and some part of Kenya, and the balancing it out with the jikaze kimwanaume. The thing we tell people that jikaze kimwanaume, how do you balance that out, the jikaze kimwanaume and pain as a vital sign, and how do you weed out or drug seekers so that the Teresas and the Brendas of this world will not be labeled with them? Whatever has caught the English that has landed in your ear, just answer.
Yeah, I think, okay, we cannot undermine the opioid crisis. There is a big opioid crisis world over, including in Kenya, and neither can we undermine the fact that some of these patients who are misusing opioids or addicted to opioids actually do have chronic pain, and that is how they got exposed to opioids in the first place and then got an addiction. Now, about pain being a fifth vital sign, that is something that is still ongoing. Some hospitals have implemented that, some have not. But the good news is in many facilities, when I walk around the country, when you look at the assessment forms that are happening in casualties that are being used, there is actually an area to document pain. There's a scale for pain, both for children and adults, and there's a bodygram for you to document where the patient has pain, and at least to remind you to ask about rating their pain. Now, when we come to the other issue of labeling patients as junkies or addicts, that is sadly a practice that is very rampant, and we are really trying to work on it by pain education, that a patient who comes in pain should be assessed for pain and their pain should be managed, even if someone is an addict. In fact, the ones who are addicted, unfortunately, need higher doses of opioids than the ones who are not addicted. and they're the ones whose pain is poorly handled. And of course, then we just perpetuate the cycle of addiction. So addiction has to be evaluated. When we are evaluating pain, if a patient has come to the outpatient 2 times in less than a month, we want to look at what is the underlying cause of the pain, and is it a gap in our care? Are we the ones who are not handling the pain well? That is why the patient is back. Then if we are noticing or we are thinking that the patient might have addiction, addiction is a psychiatric problem. It is not just that when you say there's addiction, then you rubbish the patient and do not give them any intervention. If it is true that your patient is an addict, what is the criteria that you are using to label that patient as an addict? And then what support are you going to give them? Because you have to manage their pain and then give them further intervention, psychiatric and psychological. So we are really campaigning. In fact, COVID is a good thing. It made virtual meetings very useful. People have learned how to do virtual meetings. So we do have a lot of audience every time we are doing webinars on pain assessment and pain management. And that problem of addiction and opioid misuse, we do talks about it all the time, so that the healthcare providers, when they meet a patient in pain, first is to identify the pain, manage the pain. And if you're not able to manage the pain, then you need to know who is the pain specialist to refer this patient to. If a patient has addiction, who is the right person to call to manage the patient's pain? Because their principles of pain management are a bit different from patients who do not have addiction. Thank you.
And Mukimba, could you just comment on the junction between substance use and chronic pain? What's the egg and the chicken in your case?
I think at the end of the day, it seems like almost all psychological it's a cyclic cycle, right? That yes, I think a reliance on opioids definitely would cause an addictive pattern, but as well, being in an insane amount of chronic pain would actually result in addiction. So it all goes round and round. But I think what I wanted to say before all of it was psychological problems doesn't mean it's in your mind and it should be something that should be rubbished. I feel like that becomes the huger problem, where addiction and psychological problem and psychosomatic symptoms are rubbished because they are associated with something that, again, is invisible. So it's easier to nurse a wound that you can see, but then we throw away anything that has the word psychology related to it. And that's why I was talking about like a multimodal approach, that the awareness and everybody should be involved together. Like it should be a teamwork, even when people are managing these chronic conditions and the chronic pain as well. It should be something that we should all come together and try and figure out solutions on creating awareness, and as well, advocating for the patients, because it seems it's clearly very exhausting for them to be doing the advocacy for themselves, as well as fighting the illness themselves. So that the awareness is really important. But just because it's psychological, just because it's addiction, just because it's something that we cannot see physically, does not mean it is not real. I think that's always the bigger problem, that because we cannot see these things, then they're rubbished and they are still just as important as if it was something like cancer or something physical that the doctors could be able to see and treat.
So let's think. Let's talk about the dream team and the like. If you had your own dream team to manage your pain, let's start with the people living with the pain. So, Brenda, okay? Because yours is a lot. Okay, let's see. What's your dream team? Like for what you know now, what would you have done differently 5 years ago in terms of the people you'd use to care for your pain? I don't know if it makes sense.
Like in terms of doctors, specialties?
Doctors, specialists, PT, OT, PC, anything. What would you want on your panel?
Ooh.
I know yours is a lot.
I currently have, I don't even know, I think I've lost count. I have like 30 something doctors. But I think I would keep number one, a very good rheumatologist.
Mhm.
And then an insurance case manager.
Okay. Okay, this is a US problem. In Kenya, it's a bit different. The case manager does something different, but yeah, okay, go on.
Yes.
Mhm.
And then I would get, of course, a good primary care physician.
That's a GP in Kenya.
Yes. And then I would absolutely get a therapist.
Which
Be-
kind?
Behavioral.
Okay.
No, like there's two kinds of therapists. I would say one who would do one who would be able to one to talk to, like a psychologist. And then I think I saw another one who like an impact one. They're called, you see them for like 30 minutes and you come up with like a plan you want to, like if you're going through something, they come up with a goal, and within 30 minutes, you decide what you're going to do. And it's like a whole thing for just 30 minutes. So you don't go to them every week. You see them once in a while, and it's only when you're like in a crisis and you need them. It's like an acute care,
Okay.
but for like mental health.
Okay.
I would do that. And then I would have physical therapy, occupational therapy, and then a neurologist, and
Okay.
then a good group of friends, and then a prayer, which is crazy, but a prayerful kind of people around you too, because it goes a long way. Because it gets really, really dark, and it doesn't matter that you have friends and you have doctors who know what they're doing. It gets really, really dark fighting these illnesses. And sometimes just having the faith in God and having friends who would remind you where your faith is anchored, that's what kind of gets you through it. So that's what I would do.
Trix, the same question. What's your dream team? We do not have all these things that Brenda has here. So just tell us from your Kenyan POV.
Dream team.
Yes.
Of course, as an individual that has sickle cell, you have to have at least 5 friends that you can call and say, in a crisis, you need to come now and take me to hospital. Because you see, sometimes a crisis can rob you of your limbs. You will not have the ability to use your arms. You will not have the ability to walk. So you even need someone to come help you get dressed up to leave the house and go to hospital. So you definitely need a circle of friends that are ride or die, for the lack of a better word. 1. And then 2, you do need a physician that at least knows your history, so that when you go to the hospital, you're not starting from scratch. In your pain, you're starting to describe what it is you have. You can imagine you're crying and someone is asking you, so exactly what are you suffering from? And you have to now to explain, oh, it's sickle cell. And sometimes the physician is not even conversant with the condition. So you can see them even standing in the corridor looking at their phone or some dictionary to wonder what the hell is sickle cell. It's happened before, so it's very sad. So it's actually good to have like at least a hospital that you can keep going to, that you can keep receiving treatment, that at least they have your file, that even if you can't talk, they can see and they can know what to do next. So you definitely need a team of 5 friends, because people are busy. So if one person is not available, as long as you've reached out to one person, they've reached out to the other person and the other person, so they can always decide which one can take that mantle. Yeah.
Okay. Dr. Nafula, I want you to address 2 issues. And one is, we can see it from the panel here, is chronic disease a female thing? And 2, the steps in management, bearing bearing in mind what Brenda and Trix have already told us. What's your dream team? And if you could address the XX part of chronic disease.
So chronic pain is more common among females than males. I wouldn't call it chronic disease, but some of the diseases that cause chronic pain are more common among women. So some of these autoimmune diseases, they're more common among women, the endometriosis. So women tend to suffer chronic pain more than men do. Now, when it comes to the approach towards chronic pain, I think Brenda has summarized it very well. So when you're looking at a patient with chronic pain, you have to look at 4 dimensions. You have to look at the physical pain. What is the cause of that pain? What is the underlying disease? What are the interventions for that disease? The second domain is psychology. How is their psychology affected by pain and how can you support them psychologically? Number 3 is the social aspect. What Brenda and Trix are saying, you need friends, you need people who can help you when you're in pain, you need social support, you need your family to understand that what you're going through. Then number 4 is the spiritual aspect. We have to look at how is this pain affecting your spirituality? What do you believe to be the meaning of your life, the meaning of your pain? What is your spiritual connection? And how is pain interfering with that? So when we are managing chronic pain, we need a multidisciplinary approach, and the patient is the first person in that team. So it is not just the doctor dictating that this is the drugs that you need, this is your condition, because it's the patient who is suffering the pain. We have to individualize the treatment. We have to understand the needs of the patient and then be able to give them support. So you've heard our patients say they would like a team of physicians or people who are qualified to manage pain and qualified to manage their diseases. Then you need the nursing team, you need the psychologist, you need the physiotherapist, you need the chaplain, you need friends. So you need a whole team to be able to manage chronic pain. Thank you.
Mukimba, your dream team.
I think the doctor summed it best. It's really important to listen to what the patient wants and really validate what it is that they're saying their needs are, because we often try and tell them what they need. And like we said, pain is very personal. Our personal experiences need to be validated. And I think that's listening to the patients is really important. And obviously being aware and creating that awareness on what all these things look like, because I definitely don't think it is appropriate to be in a space where your physician is doing research on some of the most common conditions. But yeah, I think creating a huge awareness on what all these things look like, and the dream team should be what the patient wants. The patient will allow us to know what they need so that they can feel validated and so that their healing can be in the speed that they want it to be, and also in the pace. Yeah. And I think prayer, like a prayer partner and all that seems to be a really amazing addition to that whole process.
Okay, as I wait for Karen to complete her question on Facebook, because I feel like it's incomplete. Saya, back to you because you're our resident chaplain. I just want you to touch on these very unhelpful things of receive that prosperity gospel does that are very unhelpful, and just prey on innocent chronic people suffering from chronic pain.
I almost have to begin by controlling myself. I have very strong sentiments against that. And how do I put this? Within the Christian faith tradition, we believe that it is God who does the work of healing. And he can do it in 2 ways. One is what we just downright call miracles without the intervention of normal medical processes. because just like, when I began talking about idiopathic, we do appreciate that at times in the medical journey, there are conditions or state where the doctor even doesn't know. And at times for some to resolve, God does come through. But then a second and legitimate way that God uses to heal people is through medical practice, because true science and true religion do not disagree because they have the same author, who is God. And so God can elect to help address pain using physicians whom he has been able to allow to get help, understanding of the human body, its processes, and how to resolve the question of disease. When individuals want to circumvent any of these, they will be working outside of the premise of divine revelation. Now, individuals who are in pain are vulnerable. The Bible talks about the woman who had an issue of blood for 12 years. And one of the defining characteristics she had is she had suffered many things in the hands of physicians and had lost everything. So the vulnerability of disease is there. And if there's one class of people whom the Bible speaks in their favor and speaks very strongly against their exploitation, it is individuals who are vulnerable, whether it is widows, orphans, or those individuals who are suffering. So any person who comes and purportedly in the name of religion wants to either A, peddle false hope, or B, use someone's disease to exploit, says if you give offering XYZ, you'll be able to get healing, or if you they attribute pain or disease to someone's failure or something like that, are actually not doing God's work. I come from the school of thought that strongly believes that you do not judge a philosophy by its abuse. And so I want to allow my heart to go out to individuals who, in their state of disease or vulnerability, have either been taken advantage of or told things that were not accurate biblically, that, hey, the God of the Bible doesn't operate necessarily in the ways the people who claim to be acting in his name do. And so specifically to the individuals who are doing this, people need to be encouraged to seek proper medical care. And when you as a theologian or as somebody acting within that space does not fully understand the parameters of a disease, I think it is only prudent to pray and then refer. Pray and refer and be able to state the sincere limitations that we do have. Because when we pray to God, Jesus' friend Lazarus was allowed to rest. And so we do not command God in prayer. And so I think we need to be frank enough to accept our delimitations and be able to refer that the people whom God has gifted appropriately in handling, managing disease should be able to do so. Then I think secondly, we need to be honest with the people who are suffering that the way God deals with the entire question of pain doesn't always line up with human expectation, but we do understand that he does all things well for the sake and for the good of his people, and that he is not oblivious to the question of pain because he himself has suffered pain in the form of a cross, and he suffered both visible and invisible pain. And so he's able to empathize and give the help that people need. And that thirdly, our pain situations are not times to be exploited, that truth still remains to be true even in those times. So I think people need to stop exploiting individuals' pain. It is not godly.
Thank you. I just want us to touch on, Dr. Nakfula, I think I'll start with you, and then Mukimba, on the role of sick rule and how individuals living with chronic pain, families, workplaces, schools can help, understand the sick role, and the individuals who are suffering from chronic pain not take advantage and neither should they be seen as pretenders. I don't know if you understand that bit, because I feel like families of people who suffer from, who are living with chronic pain are not able to see that. And some individuals who suffer from chronic pain sometimes take advantage. It's just there. I mean, like the same way some are drug seekers. I'm just wondering what tools are out there to help everyone support each other and everyone to just live with it and not have to be annoyed that someone is playing the sick role. Just help me there.
The important thing going through a journey of chronic pain is for the people around to be educated. So it's about sharing information. I do not have any tools in particular, but what I have now is just some advice that for the person going through the journey of chronic pain, it is good. I know some of these illnesses are very personal and you might not want to share, for example, with your employer, but sometimes it is good to let your immediate supervisor know that you are unwell and educate them a bit. This is what I'm suffering from. This is how it looks like. This is the medication I'm getting. So that sometimes when you're sick, the employers do not think that you're malingering and you're just taking sick offs, but sometimes it's good to let them in. And in instances where we know some bosses, the supervisors are very unreasonable, at a personal level, when I run the pain clinic, we are able to support our patients. Sometimes we are able to talk to their employers for them. We are able to provide them with some written report that explains this is what is happening. So it is good for the sick person to speak up. Now, when someone has chronic pain, it's also good for the family to be accompanying them for these hospital visits. And we need to sensitize the healthcare providers or the doctors that yes, you will see a patient and you manage the patient, but it's also important for you to spend some time with the family or caregivers and educate them. Because sometimes the way the families handle the patients is out of ignorance. It is not that they want to be mean to the patient. Some of them do not understand. And you see, human beings, most of the time we compare experiences to what we know. So if someone tells us they're having bad pain, you quickly think about the time you've experienced the worst pain in your life, and you tend to imagine that person is experiencing pain that same way. So sometimes it is good to have this, we call them family conferences, where we sit with the patient, we sit with the family, and we educate them on what is happening, especially with patients who are having chronic illnesses that need long-term care and patients that need support, because the family will not be able to support the patient if they do not understand what is happening. If they do not understand, for example, in sickle cell, what triggers this pain? What should I do when my daughter, my sister is having pain? How can I be more empathetic? Sometimes they don't realize that they are not being empathetic. So it's just to educate and educate some more. Thank you.
Thank you. Mukimba, the same question.
So in psychology, we say unfamiliarity and fear go hand in hand. So definitely creating awareness in those spaces where people, because what people don't know about, people respond to in fear responses and survival mode responses. Either they are dismissive or they're rude about it because they don't, it's something that they are unaware of. So creating awareness in those spaces, being able to talk to families like Dr. Nafula has said, it's just allowing everybody to be involved in these conversations. And I think what I would add on to is also giving the patients language for their pain. I know we say that pain is very specific, but one thing that therapy also really helps is sometimes we know how we feel, but we don't have the language to be able to describe it to anybody else. And we do not know how to get our needs met in those moments. So as well, developing some type of vocabulary, some type of language for what is happening within your body, I think also empowers the patients to be able to advocate for themselves. So that makes a huge difference, even as we involve the community and we involve everybody who is involved. We involve everybody in the whole process, yeah. It's important for the people who are suffering from this chronic pain also get the language to be able to advocate for themselves and speak out for themselves. That empowers them, I think, also a lot more.
Okay. Brenda and Trixie, what would you want us to know? Like we as your colleagues, we as your families, we as your friends, to know so that we support you in your as you live with chronic pain. We can start with the one who's in the countryside. We are jealous because it's snowing out here. Trixie. Trixie, are you still there? Okay, Brenda.
Finding the microphone was a bit hard.
Yeah.
Could you please repeat the question?
I'm just what would you want as your colleagues, your bosses, your friends, your family to know? How should we support you as you continue being warriors in pain?
If there's anything maybe I can say for myself is we don't like wuye wuye. Wuye wuye, for anyone who doesn't understand what wuye wuye is a pity party. When you're coming to throw a pity party by my bedside, we we need positive energy. You know, when you're going through something that is a bit hard mentally and also physically, you at least need people who are a bit positive around you. So when you go see someone who's unwell or who is going through at least some chronic pain, try and be, yes, empathetic, but don't overly do it. Like, don't make them feel like they are the egg, you know, because we also would want to feel like a human being, even in that state, even in that sad state, you know. So don't have pity parties by someone's bedside. Try and bring positive energy, one, and then two, when the pain is over, don't make someone feel like you're going to hang it over their heads that they are forever a weakling. It's we don't like being viewed as people who are weak. We're just human beings who are also trying to survive once in a while. So for me, I would just say don't bring the pity parties by the bedside.
Okay. Brenda?
I honestly could not have said it better. Because like there's nothing so I have to get from a wheelchair to, because sometimes I end up using the wheelchair because I can't walk much. And so from getting to the wheelchair to the car, people just make a big fuss. And it breaks my heart because I really, really don't like it. What I like is a big roast, like a good roast. Like, please roast me how I'm walking. Like my friend tells me, like, why are you walking like a penguin? And I laugh because that's exactly how she'd talk to me when I was healthy, you know? So nothing has changed. I'm still Brenda, just like make fun of me. Let's just live and let it come from a good place, you know? I agree with Trixie, we do not like that pity party thing. And the other thing is, I think I would say it takes a lot from us to ask for help. It definitely does. And so even accepting that help is hard. So don't hold it over our heads. And how do I put this? I want to put it delicately. I want to say, help us with grace and understand that if it was you in the same, we did not ask to be in this position, and we would do the same if it was you that we were helping. And the other thing is, don't limit us, don't try to limit yourself. It's always new, and we're always trying to understand this new life that we're living, especially, I'm just going to give myself as an example. 1 minute I'm walking, the next I can't move my leg. It's always something new. And so it's always an adjustment with my friends, with my family. 1 minute we can't do this, the next we can. So as we learn, it's okay to be ignorant in, sometimes I don't even know how to move a wheelchair, you know, give us ourselves, and so I imagine my sister sometimes also doesn't know how to move a wheelchair, and my friends don't know how to do stuff. Like, we're all learning, and so let's give ourselves grace to learn this new thing and adjust, and let's just be okay with learning and understand that this is new, and eventually we'll be pros at it.
Okay. I know this might be a difficult question because I know we are all supposed to plan for it, but for those of us who live with chronic illness, chronic pain resulting from a chronic illness that may lead to earlier than usual death, are we helping planning for end of life care? And we can start with Dr. Nafula. Do you put the end of life care in, as part of your, when you're counseling patients who are living with chronic pain? Mukimba, do you do end of life care planning? Is anyone okay? Go ahead. Yes.
No.
Oh,
So yeah, no.
no, it's not in
Sorry.
your real. Sorry.
I do some question, sorry.
No, I'm just wondering if for those with chronic pain, okay, you see this, if you have chronic pain, courtesy of endometriosis, that's not going to shorten your life. If you have chronic pain due to cancer or something like that, that's going to shorten your life, right? So do you incorporate end of life care in terms of when you're counseling patients?
Yeah, for us we do, because if you have a life-limiting condition, you're likely to die of the illness. It is good that as we are managing your pain, we also help you to manage your expectations, so that you have what we call, if you have any unfinished business, you can be able to do it. If you have things that you feel you need to do before you die, and you have the energy to do them, you do them. And we help your family also to start adjusting and adapting to the fact that this illness is beyond cure, and you might get to end of life at some point. So it is a discussion that we have in the course of pain management. Trix mentioned something about consistency of the healthcare provider, that it would be good if when you go to hospital, people have your file, you meet the same provider. So sometimes for these patients with chronic illness, especially the ones who are going to transition into end of life, it is good for them to work with one team, so that, you cannot handle all these problems at the first visit or the first encounter. You need time with the patient and the family, you need to work with them.
So Trixie and Brett, okay, because the two of you are like me, have you had this discussion, Mutani Chapa? Have you had these discussions with your, at least your primary care, Trix, with your Kawaida physician?
Yeah, I have. Because at least I wanted that consistency in my adulthood. Yeah, so yes, I have. And I've been looking for a hematologist. So I was replacing the one who had seen me through childhood with another one. So yes.
Oh, and my question is on end of life care, because at least for now, there's no cure for sickle cell as we know it. Have you had this discussion?
For end of life care?
Yeah, care, yes.
Like in my older life,
in your, even now, not we are too cool size, but I'm just wondering if it's something. I know it's a difficult conversation, but we all need to have it. But I'm just wondering, yeah, if you've had it.
Trix, let me comment before you answer. The end of life care, because we are all alive and we'll all die. It is important for everyone to have conversations about what kind of end of life care they want. I know in America it's called advanced care planning. It's legal, it is there, it's talked about. The Kenyan side, it might not be still it's not in our laws and it's not talked about a lot. But tricks, it is not, as one is saying, we are not killing you anytime soon. It is just something we want to know, because living with a chronic illness sometimes brings up these discussions or these thoughts. Thank you.
I haven't thought about it that far, only up to where I am, how old I am right now. But in my 80s, no, I haven't thought that far, to be honest.
Okay. You know, you have
On the other hand,
okay.
I have had to face my mortality a couple of times. So I have, unfortunately, I think it's the hardest at 32, because I was 32 when I was writing the Advanced Care Directive. I think it was one of the hardest things I have had to do. But so I have a palliative care doctor because I have so many diseases, and I gotta get help for managing symptoms and everything else. My primary care cannot do it by himself, so that's why I ended up getting a palliative care doctor. So one of the, in fact, the second meeting, we had to do an advanced care directive. And I think that was one of the hardest things I've definitely had to do. So yes, I do have that in plan, and I've had to slowly introduce my family into the idea that I might not be here for long. Not that I'm not giving up. There's a difference. It's just preparing for the future, but hoping that I will be here, because I'm a fighter. I'm still going to be here, but preparing. It's not giving up. I just wanted everyone to know that. So preparing, but it's hard. It's a very difficult conversation to have, but it is unfortunately, in my case, a necessary conversation to have.
Okay. I think, Dr. Nafula, this is a conversation we might need to start having in Kenya, because Trix is very switched on, and if she's not having this discussion, we have work to do. I think we've covered like everything that I wanted to cover, because this is it's for the lay public. It's not, we are not gonna go to pharmacotherapy and all that other stuff that we can do in medical, what are they called? Conferences. But I'm just wondering if I can do like a one last go at people, what they want to, what I missed out and what they want people to know. So let's start with the ones living with with chronic pain. So Trix, wewe ndio wa kwanza.
Okay, what would you want to know?
No, as in anything that I have left out that you want us to know.
For us, I feel like people are always giving us a death sentence. Like I do hear a lot of people who have kids that have the chronic illness, and they're like, their kids are gonna die by a certain age. Even some physicians are always busy telling parents that their kids are not gonna live beyond a certain point. So I think when you're having that conversation, even if you wanna have it, don't have it near the kids, because the kids now grow up fearful about turning age 15, then turning age 18, then turning age 25. Because for us, I grew up in the 90s. So in the 90s, many people were very ignorant about this thing. So I would just encourage anyone who has anyone who is suffering from a sickle cell disease near them, do not be that prophet of doom. One, it's not a death sentence. It's something you can always figure out how to live with, There are worse things in this world than that. Then two, you just need to, by the way, work with a physician, whether you like it or not. You just have to work with a physician, whether it's you and your child who has it, or whether it's just you who's decided to do life on your own. Yeah, you have to, whichever way you look at it, because physicians, in as much as we don't like them, they know what they're doing and they'll always guide you. So that's how you can manage and survive. I think that's the only thing I can actually add.
So Trix, does this affect like, I know because when we were still in med school those years, we used to give people with sickle cell like up to 21 because we didn't have the medical, the therapeutics hadn't advanced to what they are now. So that's what we were seeing. But my question to you, because you said no, I can ask anything, is how does it affect your ability to start a family? I know I should have asked this before. Start a family, have children. Do you plan for that, or you just want to not be a burden on someone? Is that a fair question? If it's not a fair question, just say
It is a fair question, because when you get to a certain age, you start wondering, will someone pick me? And to be honest, and now let me just put it out there, because you feel like, the way people say half a person, you'd think a guy would look at you that way, you know. But if it's someone who's well versed and not ignorant, because it's ignorance we're trying to kill. Once someone does not have ignorance, it's a bit easy to, if you like someone, at least get to know them, and then, you know, study. If you haven't studied about what they're going through, at least do a brush up on what is anemia. So I do like when I go on the first date, you tell someone, yeah, yes, in as much as I am this and that, I am suffering from sickle cell disease, and sickle cell disease is this and that. If they like you enough and they ask you for a second date, by second date, you as a person, you also ask them, so did you go and find out what a sickle cell disease is? Did you do this? Did you do that? If they were interested in you genuinely, they would have actually gone to do that research, and they'd have that conversation with you. We do have people who are getting married. We do have people who are married and do not want to venture into kids, because at least they care enough for the woman to know that it's a bit difficult to carry a kid when you're having such a disease. Life does go on, though, in as much as half the society would not want to be attached to people who have physical burdens. But it's not a big deal at the same time. You can accept whether you settle with someone, but at least settle with someone who is kind. Actually, the key word here is kind enough to take care of you in that situation, because not everyone has kindness or empathy. Yeah, but on marriage, people are getting married left, right, and center who have the disease, but it's just now, are they attached to the right person? I think that's the bigger question.
Okay, thank you. Brenda, same question. What would you want us to know? And also this, the whole getting children and leaving grandchildren for your parents.
I'm just laughing because I don't think my parents are getting grandchildren from me, but it's okay. They have grandkids from my siblings, so they'll be fine. I don't know. I've only been sick, realized, for 1 year. Like everything went south for me in 1 year. And so I haven't had the chance to even think about, like, how would dating look like outside being this, like, unhealthy, like being healthy but disabled, you know? So as much as maybe I would like to date in the future, I don't know how it looks like. It's probably not gonna be easy just from just my logical thinking, but we'll see how it goes.
Okay.
Yeah. I think the only thing I can do is nothing, like I always say, nothing is going to limit me unless I limit myself. So we'll see. What I would like people to know is Mukimba said something very important when we were starting. She said the importance of mental health and like the impact of chronic illness on our mental health. And I just wanted to echo that one last time so that people understand the magnitude of what chronic pain does to your mental health and how it can sometimes make you feel like, sometimes it's even more debilitating than the pain itself, because it's very difficult to fight your own mind. And it's important that I want to say, especially I know I'm from Kenya. And so I know we don't take counseling and we don't take therapy as important as we should. And so I just want to say or insist that if you can, get help so that we can talk through or have someone who has 1 hour dedicated to listening to you for 1 hour and help you navigate the pain and your life, and maybe even connect you with resources that you may need to get through this terrible thing that we're going through, because it gets really rough and we need all the help we can get. That's all I want to say.
Thank you. Mukimba, you're up.
Yeah, I think the only thing I would really want to reiterate is how important it is for people to tell their story the way they want to tell it, because often it is tempting to retell people's stories, you know, and I think the invalidation of people who go through any type of condition, right, is basically wanting to be the one who fills in the gaps. And I think being able to have that safe space to tell their stories, as well as come up with strategies on how to live through life on life's terms, because, you know, some of these conditions are lifetime, they are long-term. And again, psychological symptoms are not to be thrown to the side, because they are just as important as physiological conditions. And it doesn't mean that we are weak when we have moments where our minds are not working as perfectly as we want them to. It is just an indication that we need a little extra help. And awareness. I think this platform really gives me a lot of hope, because hopefully it just allows more people to feel more comfortable to share their stories. And as well, for those who had not had these conversations before, they get a chance to hear and listen and learn. So yeah.
Thank you. Dr. Nafula?
Yeah, I think what I would like to say is that we need to remember that pain is subjective and that patients with chronic pain need a lot of support from us. So we all have a role to play, and we need to do more advocacy in just people understanding how to support patients and families that are living with chronic pain. Thank you.
Okay, Saya, you're the one with the English of the news. Tufungie ukurasa.
Okay, thank you, everyone. I think of all the talks we've had to date, today's has been like the most sober, you know, not somber with an MBR, not and understandably so, like bearing the burden of pain, not knowing whether it'll finally resolve or how it will resolve is a real thing. So we hope we've been able to add one more tool, if nothing else, hope in the process. And if nothing else, in addition to the hope, maybe tools and awareness. I'm celebrating people like Brenda and Trix, who's very being here as pain warriors and pain ninjas, gives us the perspective that, hey, you can live fulfilling life. So yeah, my two sisters, I want to personally celebrate you. The preacher side of me comes in here and says, you know, there are two kinds of belief. There's people who believe because, and there are people who believe in spite of. And when you keep looking at the Bible, Jesus was keen to always point out and celebrate people who believed in spite of, more than people who believed because of. And you keeping faith alive, keeping hope alive, calling yourself fighters and believing in all things, seeking love, doing. Trix does amazing, what's it called, outfits. Brenda is a sport to laugh, and here she is with her having graduated end of last year in very difficult things. Thank you so much, because it tells us that true, the pain is not gone. The pain might check in. Who knows? God forbid, maybe after this call, Trix will text and say, guys, I'm not feeling too well again. Who knows? God forbid that should be the case, but just your very presence here tells us it's going to be possible. I want to celebrate those in palliative and supportive care, the Daktari who's joined us, and we keep praying for the efforts to get solutions to human pain, that it may go well. But all of that aside, at least today I've been reminded that actually, even that chronic pain serves a particular function. It reminds us when things are not okay. It is the thing that has made the difference between saving a life and not saving a life. So even the darkest storm can still have a silver lining on the clouds. If you're taking care of somebody who is going through chronic pain, or if you're the one who's going through chronic pain, I hope today's session gives you hope. And also I hope it points you to get all the help and all the support that you do require. And I trust that all will be well. This is Authentic Dialogues. We're committed to having dialogues that matter and having them in an authentic way. So please remember to share this wherever you get it. And remember to also share your questions and your future topics that you'd like to be discussed, because what's a dialogue if it only has one person, or what's a dialogue if the topics being raised are only one-sided? So we want to make sure it's both ways. So God bless you, and back to you in studio.
Thank you, everyone. Thank you. It's a difficult topic, and just share and asanteni sana. Thank you very much. Trixie, Brenda, Mukimba, Dr. Nafula, thank you. Asante, Mungu awabariki. And the people who joined us, Carol, Samo actually joined us as Saya. We are gonna clap later. And I think I saw Mboya later, and there are people on the Facebook side. Karen, I see you, and I see Rena Guru, one of the, or Becky Guru, and I think I saw our cousin there. Thank you very much. Please send us questions. Please send us topics you think are difficult. We will try and get the panelists. Asanteni sana, and because we are Christians, Mungu awabariki, and bye-bye.
Bye.
Bye-bye.